Good afternoon. Thank you very much for inviting me to give this lecture. Is that okay? So I thought I'd speak today just in general terms about lysosomal storage disorders and the clinical approach to them. One can, of course, talk about the management, but this is very complex. It's important to initially understand how to diagnose lysosomal storage disorders, what are the important clinical signs, and what are the challenges. The lysosome was discovered by a Belgian biochemist, Christian de Duve, who was awarded the Nobel Prize in Medicine in 1974, along with Georges Palade and Albert Claude, for their discoveries and work on the cell and its structures. Lysosomes are organelles inside the cell, so they're subcellular organelles. And their main role, it is not their only role, but for purposes of this lecture, we will just talk about one role, which is to break down waste matter. This waste matter may come as foreign cells or particles. It may come from damaged organelles from inside the cell, or it may come in the form of small molecules from outside, which are the products of breakdown, which need to be destroyed. So there are three different pathways by which the products for destruction and breakdown reach the lysosome. And inside the lysosome, there are a number of enzymes called lysosomal enzymes, which have the role of breaking down these products. Very briefly, these enzymes are all proteins, and therefore, like all proteins, they are formed in the rough endoplasmic reticulum, the rough ER, and they are transported in stages through the Golgi apparatus, the cis-Golgi, the trans-Golgi, and then they acquire receptors. These receptors are called mannose-6-phosphate receptors, or these are the most important ones. And they get tagged with these receptors. And these receptors, once they get tagged, they are recognized for transport to the lysosome. Not all proteins are tagged with these receptors, and therefore, with the mannose-6-phosphate moieties. If they don't get tagged, then they go out of the cell through another mechanism. So only those proteins that have to go to the lysosome, in other words, lysosomal enzymes, acquire these mannose-6-phosphate groups. And the lysosome has mannose-6-phosphate receptors, and which recognize these mannose-6-phosphate groups, and that is how the enzyme enters the lysosome. Once inside the lysosome, they encounter the waste product and break them down. Now, there are at least 60 enzymes known in humans, and each enzyme has a very specific role. So each enzyme breaks down very specific waste products. So, lysosomal enzymes are proteins, and each is coded for by a specific gene. And therefore, disorders of these proteins are single gene disorders. Lysosomal storage disorders are therefore single gene disorders. That's very important because it means that by modifying the gene, you can actually modify the enzyme. Now, depending on the enzyme so if the enzyme is missing, the waste product that it normally breaks down builds up. And it is the buildup of these waste products that causes problems. So this results in lysosomal storage. And depending on the enzyme, you can get problems in different parts of the body: liver and spleen, bone marrow, kidneys, brains and nerves, heart, muscles and joints, skin, facial appearance. So you can see that lysosomal storage disorders have a very wide spectrum of clinical manifestations. It's also important to remember that you have a set of defects that are the primary defects. So you have the genetic defect, which is what I talked about. This results in the enzyme deficiency, and the enzyme deficiency results in the accumulation of the substrate or the waste product that enzyme normally breaks down. Excuse me. And depending on where the defect is, you can, depending on where you want to target your treatment, you design your treatment. So for genetic defects, you can have gene therapy, etc. I'm not going to talk about treatment today, but you just need to understand the principles. But it's also important to remember that in lysosomal storage disorders, there are secondary defects. So you get the primary defects, but these trigger, it's like a waterfall, like a cascade. These trigger secondary defects, for example, inflammation, oxidative stress, energy imbalance, ER stress, and each of these may need to be managed separately. So you have primary defects and secondary defects. And the management of lysosomal storage disorders is not just about treating the primary defects. So in the case of an enzyme deficiency, it is not just about giving enzyme, but it is also about managing these secondary defects. And if the secondary problems have progressed too far, the damage may be irreversible. So let's talk about the presentation. There are a number of ways in which these conditions can present, and we'll go through them one by one. So let's talk about hepatosplenomegaly first. So here you have an infant presenting with a large liver which is not marked, and a huge spleen. And in children, one of the commonest conditions that you should think about, at least metabolic conditions, is Gaucher disease. This is a young infant with Gaucher disease. Now, normally, so if you have a big liver and spleen like this, you make the diagnosis of Gaucher disease. But within Gaucher disease, there are different types of Gaucher disease: types 1, type 2, type 3. And it is very important to distinguish between the different types. This young boy has type 3 disease, but when he just sits and you look at him, you can't tell. He's got an enlarged liver and spleen, so he could have type 1, but has he got type 3 in which the brain is involved? This is very important. And we diagnose type 3 by looking at eye movements. So this boy is sitting in a chair, and a curtain is going around him, first in one direction and then the other. And you can see how his eyes flicker from side to side. Okay. So this boy has type 1 Gaucher disease, and his eye movements are normal. Next slide. So this is a young child with type 3 Gaucher disease, and we are trying to do her eye movements in the light, in daylight. Okay? But you can see that she's very irritable, very severe. It is very difficult to see the eye movements properly. So what we do is we put her in the dark. Same child under infrared observation. Okay? Now watch. Because she is not as irritable, you can see the eyes move and then they lock at the end of the saccade. They don't come back to the center. See, they stay there. With a normal child, they'll come back. Did everyone appreciate that? Do you want me to run the first one again? Because this is okay, you just run that one again. You see how his eyes move. This is normal nystagmus. Whereas in this child, run it again. This is not normal nystagmus. Her eyes lock. And it is this locking of the saccades that distinguishes type 3 from type 1. So we were able to make this diagnosis at presentation. It's not difficult. Another good bedside technique, if you don't have this equipment, is to hold the child, get the mother to hold the child in her arms, and for the mother to spin around. So in this case, the child is stationary and the curtain is rotating, and you are inducing optokinetic nystagmus. If you get the mother to spin around, you are inducing vestibulo-ocular nystagmus, which is a different way of inducing nystagmus. It's still nystagmus, but it's a different type. So this can be done at the bedside quite easily. Okay. This is another type of Gaucher disease. My colleague Ayala Abramov in the Sharizada clinic in Jerusalem, with 2 children of Palestinian Arab origin. They have no hepatosplenomegaly. But what they do have is this. They get calcification of the aorta. It's called a porcelain aorta. It looks just like porcelain on an X-ray. You can see that? And this complication is fatal. This is what they die of. They don't die of bone marrow problems or neurological problems. They die of this. They need heart surgery. It's a very different type of Gaucher disease. Gaucher disease can also present as collodion baby. This baby, you can see as though is wrapped in polythene. This is called collodion baby. There are many other causes of collodion baby, of course. But if you have a mother who has delivered collodion baby on more than one occasion, you must suspect Gaucher disease amongst other things. So these are the conditions, the common conditions that cause hepatosplenomegaly. Gaucher disease and Niemann-Pick disease are the commonest. There are a number of other conditions which are much less common. So let's come to neurological deterioration. And it's useful to discuss neurological deterioration according to the age of presentation. So in the first 12 months, we can divide it as neurological deterioration with visceral signs, with coarse facies or facial dysmorphism, or primarily neurological. So these are 3 different groups. And accordingly, your differential diagnosis may be slightly different. So here you have 3 children who all have neurological deterioration in the first year of life, but who are obviously completely different. So in the first, this is a child with pure neurological deterioration. Here's a child who's got neurological deterioration but an abnormal facial appearance. And here's a child who you can't see but also happen to have an enlarged liver and spleen. This child has infantile GM1 gangliosidosis. This child has mucolipidosis type 2, eye cell disease. And this child actually has Gaucher disease. It's actually type 2 Gaucher disease, which tends to present in the first year of life. One important clinical point to remember with these children is that they are hypertonic. So they have increased tone, and because of that, they have abdominal rigidity. And because of that, you may not feel the liver and spleen. So what happened was with this child was that the resident who first saw the child missed the enlarged liver and spleen and wrote on the form neurological deterioration. And in the laboratory, the screen for neurological deterioration does not include Gaucher disease. So the diagnosis of Gaucher disease was missed because the resident missed enlarged liver and spleen. So nowadays we put Gaucher disease even in neurological deterioration so as not to miss it. So in the next 1 to 5 years, again, and different clinical groups, different diagnosis. Here you have a child, for example, with Sandoff's disease. You see the typical cherry red spot in the macula. Later on, you may think of Gaucher disease, leukodystrophies, and gangliosidosis. In adults, you may think of leukodystrophies or sialidosis type 1. Okay, let's move on to coarse facial appearance and dysostosis. I put the two together because children who present with a coarse facial appearance almost always have dysostosis as well. So the commonest conditions are the mucopolysaccharidosis and the mucolipidosis. And then you have some conditions which are like mucopolysaccharidosis but have different enzyme deficiencies. Then you have angiokeratomas, Fabry disease, fucosidosis, sialidosis, and psychiatric symptoms. So there are some conditions that may present with psychiatric symptoms. So let's talk about the mucopolysaccharidosis. As you know, there are different types. And you may know that there is now no type 5, there is no type 8. So there are only 7 types of mucopolysaccharidosis. And they are named after the clinicians or the biochemists who first described them. So when you get a child who you think has clinical features like a mucopolysaccharidosis, this is what you need to do. You first take a urine for glycosaminoglycans or excretion of mucopolysaccharide in the urine. And then there's a chart which you roughly follow. I'm not going to go through the details, but there's a sort of algorithm that you follow. Now, mucopolysaccharidosis type 1 has basically a clinical spectrum, and broadly speaking, there are 3 clinical phenotypes. They all have the same enzyme deficiency, but the clinical presentation is very different. So on the left, you have the most severe, which is called Hurler's disease. On the right, you have Shay's disease, which is very mild. And in the middle, you have Hurler-Shay disease, which is in between the two. It is very important to distinguish Hurler disease from the milder forms early for various reasons, which I'll come to later. And you can do that by mutation analysis. The genotypes that you see in Hurler's disease are different. You don't tend to see them in the milder forms. they also have a gibbous. So here you have an infant soon after birth, and this is a very important clinical point, that neonatal examinations in the postnasal ward must be done after removing the nappies. Now that may seem pretty obvious, but in fact in this case the resident did not remove the nappy and he missed the gibbous. You can see it's just at the level of the nappy. Had he picked up the gibbous, the diagnosis would have been suspected very quickly. As it is, it was another several weeks, during which time the facial appearance changed and the parents realized that something was wrong. So they brought the child back. Now this is the same child. You can see that early on the facial appearance is not very obvious, so it gets missed. But as they get older, it's the same child at different ages. As they get older, you can see that the facial appearances become more marked. By this age, this is when we first picked her up, it came to the attention of our team. By then it was too late for anything. These are 4 children with MPS 1, and they all have very similar facial appearances. You can see this. Not identical, but once you've seen several, you can suspect. So they have a depressed nasal bridge, they have frontal bossing, they have corneal clouding. Corneal clouding is not a completely opaque cornea. It's just a lack of a normal glistening appearance. Okay? These are 2 children with the intermediate form, Hurler-Scheie disease. They have reasonably normal intelligence, but severe musculoskeletal problems, as you can see, large tongue. And I don't know whether you notice it about this child, but he has something else. He has central cyanosis. So his lips are blue. And he actually had pulmonary arterial hypertension, which is a complication that these children get, which can be treated. These are 2 young adults with the milder form. I say milder form, but in fact, it's not that mild. It's called Scheie's disease. These are 2 siblings. This young lady had cervical instability. She required cervical fusion. She had glaucoma. She had double valve disease, aortic and mitral. She needed an aortic valve replacement. And at operation, they were not able to intubate her. So they had to do an emergency tracheostomy. And she developed reflex pulmonary edema. She had to be on a ventilator. They damaged her recurrent laryngeal nerve during the tracheostomy, so she was not able to swallow for many months. Anyway, finally she recovered, and both of them are on enzyme replacement therapy. But this gentleman here, it illustrates some of the social problems that they have. The street on which this family live have a number of families who are all related to each other. The sister gets her enzyme replacement therapy in her own home. The brother is married. He did not tell his wife that he has MPS 1, not even after they had children. So he goes to his sister's house to get his enzyme infusions. So these are some of the social problems, especially in many ethnic minorities, that we see when treating these patients. This is corneal cloud. As I explained to you, it's not a sort of completely opaque cornea, just a loss of the normal shiny appearance. So it's seen in MPS 1, 4, and 6. And here's a child who looks like as though he's got MPS, but you can see the cornea clear. So unlikely to be MPS 1, 4, or 6. So Hurler's disease, going back to Hurler's disease, the distinction from other forms, the milder forms, is not difficult, so treatment options can be discussed with confidence from the beginning. Hurler's disease, the treatment of choice is bone marrow transplantation. In the milder forms, we do not do bone marrow transplants. And the reverse, in the milder forms, we give enzyme replacement therapy, but in Hurler's disease, we do not give enzyme replacement therapy except just before a bone marrow transplant. So moving on to Hunter's disease, or MPS 2. Most of the clinical issues are the same as with MPS 1, but they have a different facial appearance. So here's a child with MPS 1. These two boys have MPS 1, and these three have MPS 2. And it is different. Okay, you need to see a few of these patients, but it is different. MPS 1, MPS 2. See the cornea? Corneal clouding? No corneal clouding. Now, MPS 2, the clinical features are very similar, whichever part of the world you're in. So here's a young boy I saw in one of my clinics in India, and you can see how similar he is to these boys. We were able to make the diagnosis almost just by looking at him. The main problem in MPS 2 is in distinguishing neurological involvement. In very young children, it may be very difficult. It only becomes obvious as they get older. And this is a problem because in many children, we start enzyme replacement therapy when they're young. And as they get older, it becomes obvious that they have neurological problems. Enzyme does not help the brain. The parents are reluctant to stop treatment, and it's not easy to stop. Here you have two boys. They both have MPS 2. He does not have neurological problems, whereas he does. You can see immediately obvious that he has neurological problems. There are some important differences. The mild form obviously presents later age. The age at death is later. There's no cognitive impairment. They tend to have more cardiac disease. The cause of death in the milder forms tends to be cardiac rather than breathing. But there are similarities between the two. They all have dysmorphic features. They all have dysostosis or skeletal problems. They have airway problems, hernia. They get spinal cord compression. Yes, this is just repeating it. It has implications for treatment because if you're very confident that the brain is affected, you may not start enzyme replacement in the first place. And remember that mild is not always mild. This is a young man with so-called mild disease, normal intelligence. He managed at home somehow. You can see how difficult it is for him to hold coins. So when he went to a shop, he would flick the coins in his hand like this to count them. He died within a year after this photograph was taken of heart disease. Similarly, this young man who's an engineer in one of my clinics in India, he's 18 and he's blind. I don't know actually how he managed to work, but he did. He was quite confident. Again, sadly, he died about a year later. These are two brothers, again, in normal intelligence. They both, as you see, have large heads with raised pressure in the brain. This one has already lost his vision. The anesthetist, this is the reason he lost his vision is because of pressure in the brain. Okay, so in children and young adults, hydrocephalus or increased intracranial pressure does not cause nausea and vomiting. it very often causes just loss of vision. The anesthetist did not want to operate on either of them. They have both passed away. Here, you sometimes see MPS II in females. Okay, here's a young lady. She looks quite normal, actually. She does, I don't know if you notice, but one side of her face is larger than the other. So she has facial hemihypertrophy. But apart from that, in normal intelligence, so this is a result of, in females they have non-random X inactivation. All females have non-random X inactivation. In her case, the mutation was inherited from the father, not from the mother. And she had a normal twin. But the normal twin had equal use of both X chromosomes. Okay? So the normal twin had no hunters, whereas Naomi did. Sanfilippo disease, MPS III, there are 3 stages. Basically, they have progressive disease. And the important one to remember is stage 1. They get frequent upper respiratory infections. They are very difficult to control, but the parents think, oh, they're just naughty children because they're very young. And it doesn't occur to them that there might be something more serious. As the disease progresses, you start getting the typical problems of stage 2 and stage 3. So in stage 2, they're hyperactive, explosive rage, swallowing difficulty, progressive loss of skills. Stage 3, they have loss of mobility, progressive quadriparesis. The problem is not making the diagnosis at this stage. So this child was diagnosed at the age of 2, not because the parents suspected it, but because the older brother, there's one of 4 children, the older brother, aged 9, had just been diagnosed with the condition. So the tests were done on all the other children, including her identical twin, and all 4 were found to be affected. You can just imagine how terrible it must have been for that family. Obviously, had the diagnosis been suspected in the first child, then it could have been looked for during pregnancy and so on, but it was missed. And this is a child with Sanfilippo in the later stages with very all typical features. This is not the age when you want to diagnose them. He had 2 younger brothers, and they were diagnosed only after he was diagnosed. All 3 affected. So you want to diagnose at this age, but you can see how difficult it is. Morquio disease is much easier. You get early presentation with skeletal problems, dysostosis. It's very visual, so it tends to be picked up very early. You can see this young lady, very obvious. But it may be mild. So this is another young lady. It's in the same room, as you can see. But you can see how much taller she is. She has also got Morquio disease, but very, very mild. Sadly, I think that she was about 19. She passed away at the age of 25. She was about 28 when this was taken. She's gone on to have 3 successful pregnancies. Very different. There's another young, actually he's in his 40s, so not young, but he's from Northern Ireland. And in Northern Ireland, they get a very mild form of Morquio. So he was working in a government office. He's only recently retired at the age of 55. One of the oldest known Morquios, actually. In MPS 6, they get skeletal problems, facial problems, but they have normal intelligence. You can see that very typical MPS 6 brother and sister. All these children have MPS 6. And you can see that the facial features of MPS 6 are different from the facial features of MPS 1 and 2. Now, these are brother and sister, and they both have MPS 6. He's older, but he looks younger. The reason is that he's had a bone marrow transplant, and she has not. She's on enzyme replacement therapy. And the reason for that was when he was diagnosed, enzyme replacement therapy was not available. So he had to have a bone marrow transplant, which was the only treatment available in those days. In her case, enzyme was available, so we treated her. But actually, he's done a lot better. So nowadays, we're thinking that for some of the severe MPS 6 patients, bone marrow transplant may be a reasonable option. We shouldn't automatically put everybody onto enzyme replacement therapy. So here you have this young man with MPS 1 again. Now here's a young lady who was referred to us from Qatar in the Middle East. She had been diagnosed as having Morquio disease. Or you can see that she does not have Morquio disease. She's 13, she's very small. She has dysostosis, but she's got corneal clouding. And her facial appearance is not typical of Morquio disease. So she has MPS 6. This lad has MPS 2, as I explained. Again, this young lady was referred to us from Kuwait. She was actually referred to us for treatment for a shunt. She had hydrocephalus. She already had a tracheostomy by then. She was blind from her raised intracranial pressure. But you can see that she's got corneal clouding. This does not look anything like Morquio's disease. Again, she also had MPS 6. Mucolipidosis, there are 4 known types, but only types 2 and 3 are lysosomal storage disorders. The distinction between them is usually clear-cut. This is mucolipidosis type 2, and that's type 3. Now, type 3 is very interesting because many rheumatologists see type 3 and don't diagnose it. And only, as it becomes very obvious that there's something else going on, they tend to present with joint problems. But so they tend to be diagnosed quite late. Alpha-minus idosis. These are 2 patients with alpha-minus idosis, a child and an adult. Now, these are brother and sister, okay? Now, this is very surprising. In most lysosomal disorders, the condition breeds true. In other words, if one sibling has one phenotype of the disorder, the next sibling will have the identical phenotype. That's not the case with monocytosis. It's an exception. So this is Matthew when he was young. He presented with massive splenomegaly. And so the spleen was removed, and the pathologist said this is monocytosis on examination of the liver, of the spleen. So he was diagnosed when he was 14. Karen, his sister, was 14 years older than than Matthew. She was working. And Matthew, by the time we diagnosed, was completely incapacitated. He was in a nursing home. Karen was independent. She was working in a chocolate packing factory. So very, very different phenotypes, but same diagnosis. Okay, beta-galactosidase deficiency is unique because there's just one, sorry about the spelling of enzyme there, one enzyme, but 3 substrates, therefore 3 different phenotypes. So you can get this condition, which is Morquio B, or this condition. Now, this young lady is very interesting because she presented to the rheumatologist. She presented with joint pains. And she had been treated for years as rheumatological arthritis. Then, because routinely the rheumatologists always get the eyes looked at, she was sent to the ophthalmologist in our hospital. The ophthalmologist looked at the cornea and said, this is not arthritis, rheumatoid arthritis. This is a lysosomal storage disorder. So she was referred to us. And on careful history, we found that she was always very slow at handwriting in class. She was always last in all the school races. She used to cramp, her hands used to cramp very easily when writing. And what she had an extrapyramidal disorder. She had basal ganglia involvement due to beta-galactosidase deficiency. She had GM1 gangliosider, same condition, but two different substrates and therefore two different phenotypes. Then moving on to Salla disease. This is very rare, first described in the town of Salla in Finland, and therefore in the Finnish population there's a founder effect. Very rare outside Finland, and when it does seen outside Finland, they tend to be quite severe. The Finnish patients tend to be quite mild. This is a Turkish patient with Salla disease, very severe, exactly like Sanfilippo disease, the clinical problems. Aspartyl glucosamminuria, again, very slowly progressive disorder, again, very rare outside Finland. So this is a very typical facial appearance of aspartyl glucosamminuria. See the prognathism of the lower jaw, the heavy eyelids. These are three siblings who came from Azerbaijan, and I don't know if you can figure out which is, but he's the normal one. They both had aspartyl glucosamminuria, and you could, as soon as they walked into the clinic, you could tell that that was the diagnosis. These patients have slow neurological progression, but the major problem is sleep. They don't sleep at all. If you think you have seen sleep problems, you haven't seen these patients. I have never seen such severe sleep. These patients don't sleep at night or by day. I don't know how they manage. Then you can get non-immune hydrops, which means hydrops which is not due to rhesus incompatibility. Again, a long differential diagnosis, very important to remember that. Cardiomyopathy. Different conditions can cause cardiomyopathy. Here you have two different types of cardiomyopathy. On the left you have MPS I-H, Hurler's disease, and here you have Pompe disease. This is a very severe hypertrophic cardiomyopathy. See the thickened myocardium. Here the myocardium is not thick, but you see this sheet. We used to call this, in the old pathology textbooks, we used to call this endocardial fibroelastosis. And we now recognize that many of those children actually had Hurler's disease. So this young lady was referred to to the Brompton Hospital just down the road at the age of 6 weeks in heart failure. And because the Brompton Hospital have, in their screening for heart failure, they include mucopolysaccharidosis, she was diagnosed immediately. She had a bone marrow transplant immediately. She had two, in fact, and she is now 34 and very well. And her cardiomyopathy of congestive heart failure has completely vanished. Angiokeratomas. Many conditions give you angiokeratomas. Fabry is the commonest. Here you can see angiokeratomas on the lips. Periumbilical. Psychiatric symptoms, as I mentioned, MPS III and late onset MLD. This one's very important. So we had a young, actually a 40-year-old gentleman who, his first symptom of late onset MLD was when he forgot the way home. He went to where he drove to the work. He couldn't remember the way home. That's it. So early onset frontal lobe signs. He had a younger sister with MLD, but he was frightened. He had a family and he was frightened. of making the diagnosis. Within 6 weeks, he had rapidly deteriorated. By the time he came to clinic, he had such severe amnesia that by the time he started a sentence, by the time you started a question, and you came to the end of the question, he forgot what the beginning of the question was like. Excuse me. Sometimes the clinical phenotype may be affected by psychosocial problems. This is a young boy who came to the clinic in India, and he was found in the railway station. Now in India, you have these large railway stations in the large cities where many children run away from their families, or they just lost, and they just get onto the next train and they end up in the large railway stations, and you see groups of them. They're looked after by the railway staff actually on the platform. In fact, they even have classes and things, and it's quite well known this. So the railway staff found this young man running around. They took him to an orphanage. The orphanage realized that there was something going on, so they brought him to the clinic. And you can see that he's got odd-shaped hands. You couldn't go anywhere near him. He was almost like an animal. Okay, you can see he's covered in dirt. He used to run and crouch on the floor just like an animal, actually. He had no speech, nothing. We couldn't do any blood tests or anything. So we didn't know what the diagnosis was. Well, he died in a cholera epidemic, but by then the home had traced him back to his brother. That's his brother I showed you earlier. His brother had MPS II, her Hunter's disease. So quite clearly, the diagnosis in him was Hunter's disease. But he, who was a lot younger, he had no neurological symptoms at all. He had very severe neurological problems. So in his case, we think that the psychosocial deprivation may have modified the clinical phenotype. Otherwise, these two should have had exactly the same phenotype. We can't explain it. I've just put one extra slide here from my original talk, and that's important that selected cohorts should be screened for lysosomal storage disorders. For example, hypertrophic cardiomyopathy, if you screen all patients with hypertrophic cardiomyopathy, a small number of them may have Fabry disease. Renal dialysis patients, again, a small number may have Fabry disease. Unclassified limb girdle muscular dystrophy, a small number may have late onset Pompe disease. So I just want to end with two clinical lessons. The first is sensory neural hearing loss. Now, I don't know, but I'm guessing many of you are pediatricians. Sensory neural hearing loss in a child is pathological acquired sensory neural hearing loss in a child, not congenital, is pathological unless proven otherwise. So we had a patient, a boy referred to us, and at the age of 4, he was diagnosed with sensory neural hearing loss. There was no family history, nothing to suspect a genetic condition. He was simply given a hearing aid. That's him at the age of 8. Clearly, his problem is not just hearing loss. He's got spasticity, he cannot stand on his own, he's not continent. He has metachromatic leukodystrophy. By then, 2 more siblings had been born, both affected. Now in his case, actually at the age of 4, maybe he could have had a bone marrow transplant. Obviously at this age, far too advanced. Also, the disease in the 2 younger siblings might have been prevented by prenatal diagnosis. So that's the first one. The second is squint. So again, acquired squint in a child is always pathological unless proven otherwise. This is a young boy from Pakistan who was referred, he actually developed, you can see, a convergent squint in Pakistan. Well, he presented initially with some chest problems, so they thought it was tuberculosis. They started treating him, and then he developed the squint. So then they thought the squint was related to his treatment. So by then the parents were getting very anxious and they took him elsewhere. He has Gaucher disease. And the reason he has a squint is because he's got involvement of the brainstem. The sixth nerve nucleus is involved, not because of his anti-tubercular treatment. His lung disease was Gaucher lung disease. He is now on treatment. I saw him, in fact, a few months ago when I went to Pakistan. He's in his 20s. He's doing quite well. So that's all I had to talk about. I hope you found this useful.